Hello, this is Jonathan Edelheit, Editor-in-Chief of the Healthcare Reform magazine, here today bringing you a webinar on post-election Affordable Care Act briefing. Our co-panelist today is Ben Conley, an attorney and specialist in healthcare reform from Seaforth and Shaw. We're going to be covering a couple different topics today. And first, I'd like to just provide a little legal disclaimer that the contents of the presentation is not to be construed as legal advice or a legal opinion on specific facts or circumstances. It's material that's intended for general information purposes only, and you're urged to consult a lawyer concerning your own situation and any specific legal questions you have. We'll also try to cover some of the questions at the end. So obviously, I think this is a very important webinar we're covering today, and that's because just last week, President Obama was reelected. There were a lot of people that were waiting to see the results of the election, and that if Romney won, would he potentially repeal health care reform or make changes in health care reform, and therefore should everyone be kind of sitting on the sidelines waiting till the elections to really see if they move forward with implementing, complying, or what business decisions they'll make based upon the elections. So since Obama has been reelected, what it really means for the health care and insurance industry is the health care reform law is here to stay, that the state exchanges are moving forward, employers need to start complying with health care reform, and insurance agents and consultants must stay on top of the rules, regulations, and compliance issues. So what is a health insurance exchange? For those of you, most of you know what a health insurance exchange is, but what we're going to try to do is cover, just one or two slides on some of the basics, and then what's going to happen with exchanges and what's going on in different states. But I think it's important because there's been a lot of people that haven't really focused on some of the issues that we'll cover today, both me and Ben, because they've been waiting to see what happens with the elections. So we really also want to cover some basics. A health insurance exchange is going to be the main portal to shop for coverage in a way that permits easy comparison of available plan options. And there's going to be three forms of exchanges moving forward: state exchanges, a federal exchange, and private exchanges. Now, if we look at state versus federal exchanges, all the states have until November 16th, which is tomorrow, to decide whether or not they will establish their own state exchange. Now, this only means that states need to provide a yes or no. The actual details of how they're going to do it and what they're going to include and things like that can come later on December 14th. And those dates obviously can change if the HHS and White House provide states a little more time, as some have requested it. And if the answer is no, that a state is not going to implement an exchange, then the federal government will establish one instead. So if we look at states who are already moving forward with exchanges, this includes California, Oregon, Minnesota, Washington, Nevada, New Mexico, Utah, Colorado, Kentucky, West Virginia, Vermont, Connecticut, Massachusetts, Mississippi, Rhode Island, Hawaii, and the District of Columbia that are building their own exchanges and moving forward. So for those of you in states that maybe they haven't made the decision, looking at these other states as case studies as they start to implement it will give insight to how both the state and federal exchanges will work. For states who have declined but are going to partner with the federal government, only 4 states so far have refused to create their own exchange but are going to work with the federal government in partnership, and that's Arkansas, Illinois, Delaware, and Michigan. And some of this has to do with a budget issue that the states either don't feel they have the budget or the manpower. Partnering with the federal government will allow the states to still retain some control of the process. And states who decline creating their own exchange have until February 15th to decide to partner with the federal government. States that are still on the fence are Idaho, Arizona, Nebraska, Tennessee, Pennsylvania, Indiana, North Carolina, New Jersey, Oklahoma, and Wisconsin, who are still deciding. And of course, they have till tomorrow to make the decision. If we look at insurance rebates, the Act required starting August 1st of 2012 that insurance rebates be provided. I think many of us who are in this industry have seen over the summer the first rebates coming in, and obviously it's 80% of individual business has to go towards medical claims, 85% on group business, and it's estimated that insurers will pay out about $1.1 billion in rebates in 2012 according to the HHS, which comes to about $151 per household. And some of the statistics we're going to be giving today are from the Kaiser Family Foundation, who really is an excellent resource on healthcare reform and insurance in the U.S. It stated that only 14% of companies owe rebates, and many of these are large companies like Aetna, Cigna, Humana, and United Healthcare. Obviously, self-insured companies and rebates, self-insured companies are exempt from the rebate rule, and so is Medicare and Medicaid. And with that, I will yield the rest of the presentation to my esteemed co-panelist, Ben Connolly.
Thanks a lot, Jonathan. And just to take a step back for a second, because I know that we have a broad-ranging audience and a wide array of knowledge on the phone, I'd like to do just a broad overview of what really happens in 2014 under the new healthcare system. And 2014 is really the focus of healthcare reform. In other words, there's been a lot, especially for people who work with employer-sponsored group health plans, there have been a lot of elements that have been implemented to date, and you probably feel exhausted based on all you've done, but get ready because there's more coming. And let's just give a brief overview of what the system looks like today and how it might change going into 2014. So the United States of America, as you can see, with approximately 311 million people. Now, throughout the country, healthcare, people get healthcare through a variety of different avenues. The most prevalent is employer-provided coverage. In fact, it's estimated that 61% of the non-elderly population gets healthcare coverage through their employer. Now, if you don't get coverage through your employer, there's also there are individual policies available. One of the biggest issues with the individual policies, though, is that people find them, in essence, cost prohibitive. It can be very expensive because you're rated against yourself. In other words, the insurance company looks at you and estimates how much they think you're going to cost them and sets your premium accordingly, as opposed to if you get coverage through an employer-provided group plan, you're rated against that population, and while you might have some unhealthy people, you have equally healthy people balancing out the cost. Obviously, there's a significant portion of the population that does have what is, in essence, government-provided health care, where you go to the doctor and the government pays the benefits. And that comes through systems such as Medicaid, Medicare, and TRICARE. Finally, there's this huge portion that is uninsured, and it's a significant portion of the population. It's estimated that 50 million people are without health insurance in today's society, which is about 16% of the population. Now, let me tell you why that's an issue. It's estimated that the average individual who has health insurance pays, on average, an extra $1,000 per year to help cover the cost of people who don't have health insurance. And the reason why that happens is that there's also a law in the country that says emergency rooms may not turn away any person who walks in the door with an emergency situation. So well, doctors, while we like to think of doctors and hospitals as good-natured, they still want to make money. And so if they're treating these people, if they're required by law to treat anybody who comes through the door, many of those people don't have health insurance. They have to make up the money somewhere else. And that's where the costs get pushed on to everybody else. The other issue there is that obviously the emergency room is one of the least effective areas to provide health care. It's very expensive, very inefficient. So the hope is that if the Affordable Care Act were to expand coverage, it would bring down costs for everyone. So let's talk about how it intends to do this. The first piece is something known as Medicaid expansion. Now, I mentioned, Medicaid was, or there is government-provided health care in the country currently, and Medicaid is one of those methods. And Medicaid helps serve the elderly and poor population, primarily the poor population. Under the Affordable Care Act, the law, as it originally passed, required states to expand their Medicaid to reach 133% of the federal poverty level. So anybody at or below that level would theoretically have access to free health care. Now, Supreme Court ruling in June kind of blew a hole in this piece because while previously the Medicaid expansion was mandated, now it is optional. So as we're going to discuss in just a second, you're going to see states taking a varying approach in terms of whether they choose to expand Medicaid. Another important element here is the guaranteed issue requirement. Now, as I mentioned, there are a number of reasons why individuals don't have health care coverage today, but one of the biggest reasons is something known as pre-existing condition exclusions. As I mentioned, insurers look at each individual in today's society when determining how much to charge for health care. If they see somebody who has expensive medical condition, like let's say cancer, they know that that individual is never going to pay enough in premiums to offset the amount of costs that are going to be paid out. So they essentially deny that individual a policy or deny coverage for the cancer treatments. That goes away in 2014. It's already partially gone away for children, but starting in 2014, the guaranteed issue requirement kicks in, and insurance companies are required to issue a policy It covers all underlying medical conditions, regardless of whether the individual has any pre-existing conditions. The next piece here is, sorry, bear with me for a second. The next piece is something known as the community rating requirement. See what we can do here. I may have lost control of my slide deck here. I don't know if, Daniel, can you advance?
Give us one moment, Ben.
Oh, there we go. Okay. All right. Along with the guaranteed issue rule, there was something known as the individual mandate. Now, the problem with having a guaranteed issue requirement is that anytime anybody gets sick, they can wait and just go buy health insurance after they get sick. There's no reason to push you into the system early. To incentivize people to go into the system early as opposed to waiting until they get sick, the law includes something known as the individual mandate, and that essentially taxes individuals if they fail to get health care coverage. So the idea is you get everybody to buy in on the front end when they're healthy, and then when somebody gets sick and they have to be covered, the law would pick up that element as well. To provide a marketplace for individuals to help purchase coverage, the law creates what is known as an exchange, and Jonathan talked about that a little bit, so I'm not going to go into too much detail there. Now, the one thing I will mention is on the exchanges, there's something known as community rating requirement, which limits the variance in terms of the premium charged for young, healthy individuals to the premium charged for older, perhaps sicker individuals to a 3-to-1 ratio. So in the exchanges, individuals are going to pay, young and healthy individuals are going to pay a little bit more, but older, sick individuals are going to pay a little bit less, with the idea that everybody's going to be old and perhaps sick at some point in their life. And the final piece, and this is part of the comprehensive scheme, although probably more on the periphery than any of the others, is the employer mandate. I'm going to get into more detail there, but what that really is a requirement that employers either provide health care coverage or pay a penalty. So let's talk about what might happen here. We showed this map earlier and where individuals currently get health care coverage. The hope is that if things go according to plan in 2014, the uninsured population will shrink such that you end up with only 18 million people uninsured and only 5% of the population uninsured. And the idea is that the fewer uninsured people you have, the more effective care and more effective delivery of care you get nationwide, and the lower the emergency room costs and other unexpected costs. Now, this map isn't intended to single out Florida. Florida was just simply the state that had closest to 18 million people. And I know Jonathan's from Florida. I love Florida. I don't mean to. That's just representative of the size of the population that would still be uninsured. Okay, so let's talk about what happened in the election. Now, the big emphasis here, and Jonathan already touched on this piece just a little bit, is that people who have been waiting to see what happens need to start taking action at this point. You know, we had a webinar before the Supreme Court decision, and we said we think this is still going to be around afterwards, and it still is. We had one before the election. We said we think it's still going to be around afterwards, and it still is. Now there are very few avenues to challenge the law, and most expect that it will go into effect. And even the Republicans in Congress have conceded that this is now the law of the land. Now, that being said, we might see some tweaks. You know, there are a lot of smaller elements of the law that create issue and that are uniform, that there's uniform agreement that they might need to be cleaned up or resolved. And so we might see tweaks here and there, but most importantly, there's a huge portion of the law left to be implemented, and we've had very little guidance on how that's going to work. So within the next month, and perhaps within even the next 2 weeks, we're going to see a slew of regulations come out that make the regulatory scheme even more complex and makes it even more important to stay on top of things and find out what the latest developments are. Now, there are a couple things to watch, though. As I mentioned earlier, the Medicaid expansion may not go as planned. Originally, it was going to be all 50 states. In essence, the federal government was going to force their hand, but now they really have a decision. So it's going to be interesting to see, and we'll talk about this a little bit more, which states choose to expand Medicaid and which states don't. The same goes true for the exchanges, and I know Jonathan talked about that, so I'm not going to touch base on that anymore. But states can choose whether to allow the federal government to set up the exchange or whether to allow to set up the exchange on their own. There are still a few legal challenges pending. Specifically, there's a challenge to the law's contraceptive mandate that non-grandfather plans have to provide free contraceptive care. And that one's been in the news a little bit, so I'm sure you've heard about it. But a number of employers with religious beliefs have challenged that as a violation of their religious freedoms. So that's something to watch. That being said, that is not expected to derail the overall comprehensive regulatory scheme on the whole. The other legal challenge, which is a little more interesting and could strike more potential damage into the structure of the law, but isn't likely to go anywhere, is a challenge to the delivery of tax credits and subsidies through the exchanges. Now, individuals who are of qualifying income levels can go into the exchanges and purchase health care coverage, and if their levels are low enough, the federal government will essentially help them pay for that coverage through tax credits and subsidies. Although due to a flaw in the way the law was written, it appears that there's an argument that could be made that those tax credits and subsidies are only available if the state sets up the exchange as opposed to if the federal government sets up the exchange. Now, many have argued that this lawsuit isn't going to go anywhere because it was clear what the legislators intended, but it is a drafting error in the law, so it remains to be seen what the outcome will be there. And finally, the most important element, and really the 800-pound gorilla in the room, is the employer response to the mandate. Now, anecdotally at the outset, we heard a lot of employers say the penalty, which we'll discuss in greater detail later, is significantly less than the cost of coverage, so why don't I just drop coverage and get out of the healthcare game entirely? Now, in reality, we haven't actually seen that playing out as much, but you could see a snowball effect to the extent that a number of large employers start to drop coverage. It seems to me, just kind of following the news and employer decisions, that nobody has taken that leap yet. You have seen some employers take action to limit the hours that employees work so that they don't become eligible for health care coverage and are not required to be provided health care coverage. But we have not yet seen any large employers really just say we're getting out of the game entirely. So something to watch there. So let's talk a little bit about how individuals get coverage, and then we're going to walk through how the employer mandate works. So individuals have a lot of choices here. You start out and you look to see whether you are eligible for Medicaid and if your state has in fact expanded Medicaid. Now, Medicaid will still exist in states that haven't expanded Medicaid. It just won't be as broad-reaching. So Medicaid is free health care coverage. So it's likely that if an individual is qualified for Medicaid, they would likely go to the state and get Medicaid for free. If that's not available or if they're not eligible, they may instead turn to their employer for coverage. Now, as we'll talk about in a second, one of the big elements, well, if your employer doesn't offer coverage, you kind of walk south here on the chart, and then you have an option to go get coverage through the exchange. The exchange is kind of going to work like Medicaid, but you're going to have to pay more out of pocket. In other words, you can get you can get health care coverage there, and the federal government may help you pay for that health care coverage, but you will have more out-of-pocket costs. On the other hand, if your employer offers coverage, you'll likely go through your employer to get coverage, unless that coverage is what is known as unaffordable, which we'll discuss, in which case the employer might be subject to a penalty, and you might still be able to go to the exchange to get a tax credit or subsidy to help buy health insurance coverage. Now, here's just from an overview. We talked about the Supreme Court decision and how that impacted Medicaid, but here's the federal poverty level for your reference. Now, remember, if a state chooses to expand Medicaid, they would expand it to 133% of the federal poverty level. And here's a breakdown in the right-hand column of about where that is. So as you can see, especially for individuals with larger families, a large portion of the United States who works full-time but at a minimum wage job would probably qualify for Medicaid in many of these instances. On the flip side, a lot of states have come out and said we're not going to expand Medicaid, and this chart sort of shows that breakdown. And you know, interestingly, I know Jonathan talked about the exchanges earlier. The states that are setting up exchanges in many ways correlate to the states that are expanding Medicaid, so that's a good sense for which direction states are headed. So let's talk about the employer mandate, which is the thing causing most employers heartburn. Now, the threshold question when you're looking at the employer mandate is, does the mandate even apply to me? Generally speaking, the mandate only applies to large employers, which is defined as someone with 50 or more full-time equivalent employees. A full-time employee, not a full-time equivalent, but a full-time employee is an individual working on average 30 hours a week. But you still have to consider your part-time employees just for purposes of determining whether you're subject to the mandate. This graphic kind of shows how it works, but you add up your full-time employees, you add up all the hours worked by your part-time employees in the month and divide by 120, and that fraction you add to the full-time employees, and that gives you a full-time equivalent. If that purple circle, the circle on the right-hand side, is greater than 50, you are subject to the mandate. On the other hand, if it's below 50, you're not subject to the mandate, and you are not required to offer health care coverage. If you choose not to offer health care coverage, you will not be subject to a penalty. Now, you're obviously free to do so, and the law actually contains a number of tax credits and incentives to entice smaller employers to offer coverage, but you're not required to do so. Now, just one quick reminder here, the IRS aggregation rules apply here. So to the extent that you are a company that is smaller than 50 employees, you have to ask yourself, am I part of a larger corporate family that would subject me to the mandate? In essence, will it push me above that 50 employee count? Now, the controlled group rules, the aggregation rules, are complex, and we could do another 3-hour webinar on that alone, so we're not going to talk about it here, but just something to keep in mind. Okay, so let's talk about what the mandate actually requires. Generally speaking, if you are a large employer, so now we're only talking about employers who have 50 or more employees, if you are a large employer, you are required to either offer coverage or you'll be subject to a penalty of $2,000 per full-time employee. Now remember, we considered part-time employees for purposes of determining whether you're a large employer, but you are not required to offer coverage to part-time employees. In other words, once you've determined you're a large employer, you can disregard your part-time employees and only focus on your employees. You have to offer them coverage, otherwise you might be subject to a penalty. Now when you're calculating the amount of your penalty, you are permitted to subtract the first 30 employees before calculating. So it's in essence a deduction on the amount of tax you have to take. Now let's say you offer coverage. You offer coverage to all your full-time employees. That coverage must still be affordable, otherwise you could still be subject to a penalty. The penalty for offering unaffordable coverage is $3,000 multiplied by only by those full-time employees who receive a credit or subsidy through the exchange. So in other words, if you fail to offer coverage, it's a blanket penalty that applies to your entire population. If you do offer coverage, but it's unaffordable for certain people, your penalty only applies to those individuals for whom it is unaffordable and for whom receive a tax credit through the exchange. Affordable coverage has two meanings. The first is that you look at the premium the individual is paying, and if the premium exceeds, the self-only premium exceeds 9.5% of that individual's W-2 wages, then that coverage would be unaffordable for that individual. On the other hand, the second piece is looking at the actuarial value of the plan, and this is more of a plan-wide analysis as opposed to an employee-by-employee analysis. If the plan pays, on average, at least 60% of the health costs incurred, that plan will be considered affordable from that perspective, but you still do have to look at the premium cost charged to participants. Now, one thing to note here, the law does, in fact, require large employers to offer coverage to both employees and their dependents. That being said, the affordability piece, at least the premium piece, only applies to the cost of self-only coverage. In other words, if you're required to cover dependents, if you do so but you charge them 100% of the premium costs, you will still be okay under this law, meaning no penalty. Now, let's talk about what a full-time employee is. Now, we had one discussion earlier when we were talking about full-time employees for purposes of calculating the threshold. Am I a large employer? Once you're a large employer, the determination becomes a little more complex. Generally speaking, a full-time employee is anybody who works 130 hours per month on average. Now, the good news here is that we thought that this was going to be a situation where employees are fluctuating in and out of full-time status, and you were going to have to stay on top of it on a monthly basis and determine, do I have to offer this person coverage? The answer is no. You are permitted to use a look-back and stability period, or a measurement and stability period, where you measure the employee's full-time status on the front end and then provide them coverage on the back end. So the way that this works is you choose a length for your measurement period. You're permitted to choose anywhere between 3 and 12 months. During that stretch, you measure your employees' hours. You don't have to offer them coverage during that stretch. You're just measuring their hours. Once you get to the 12th month, if they are a full-time employee, you do have to offer them coverage. On the other hand, if they haven't satisfied full-time status, then you don't have to offer them coverage. The stability period, on the other hand, has to last. In other words, the time when you have to offer them coverage has to last at least as long as the look-back period, and it can't be shorter than 6 months. So even if you only use a 3-month measurement period, you have to have at least a 6-month stability period, and it has to go at least as long as the measurement period. So that's the flip side of this whole equation, is while you might be able to hold people out on the front end, on the back end, if they've satisfied it, even if they start dipping below full-time status, you still have to continue offering them coverage, unless they leave your employ, obviously. So let's talk a little bit more about what this means. I mentioned the look-back and stability period. That is only available if you don't know whether the employee is full-time. In other words, the IRS has said, if you know these people are full-time, why are you measuring them anyway? You have to offer them coverage within 3 months. On the other hand, if you hire somebody who might be a short-term seasonal employee, or you're not sure how many hours they're going to work, you can use this look-back and stability period, and it can stretch up to a full 12 months, and then coverage doesn't have to begin until the start of the 13th month. So in other words, for your variable hour employees, your people who you don't know if they're full-time, you don't necessarily have to offer them health care coverage for up to 13 months. So that's just something to keep in mind when you're measuring this, and that's really a mitigating factor that I think is going to help a lot of people. Now, it's very important to determine whether you do in fact have a variable hour employee. In other words, you can't just label everyone as a variable hour employee to get this 13-month window. It is based on facts and circumstances at the date of hire, and if you can't determine, and essentially if you cannot determine that the employee is reasonably expected to work at least 30 hours a week or 130 hours a month, then you can treat that individual as variable hour. So here's just some examples of who might be considered a variable hour employee, but the one thing to remember here is that it does have to be a reasonable good faith interpretation of that employee as to whether they're a variable hour or full-time, because you could be subject to audit in this instance, and you want to make sure that you can demonstrate that you've made the proper determination. So just a few more slides here, and then we're going to wrap it up. So a lot of people have said, all right, now I know I have to offer coverage. How much is it going to cost me? And that is the million-dollar question. One thing I will say is that, at the outset, a lot of people said, $2,000, this penalty is significantly less than the actual cost of providing health care coverage, so I'm just going to pay the penalty. I'm going to get it out of the game. But they failed to take into consideration a number of factors before they make that determination. Now remember, if you don't offer coverage, it's $2,000 multiplied by all your full-time employees. On the other hand, if you offer coverage, you're going to have some opt-outs. You're going to have some people who go to other places. You can charge a premium to the employees. The amount you pay for health insurance coverage is tax deductible. So there are a number of factors there that would mitigate the cost of offering coverage. Now, what I will say is that, well, here are a couple important points to keep in mind, and then we'll walk through an equation of how you might get a better sense for which employees you're going to have to offer health care coverage. So remember, you're not required to pay 100% of the cost. You can require your employees to contribute, and for those employees who are making more money, you can actually require them to contribute more to their premium. In other words, have a sliding scale for premium contributions. And you're always allowed to discriminate against the highly compensated employees. You're just not allowed to discriminate in favor of the highly compensated employees. You can also charge full cost for the dependent coverage. Second, you're only required to offer coverage. In other words, if you offer a health plan and it satisfies all these employer mandate requirements, if that individual turns down your health plan, you won't be penalized for that individual, even if they go to the exchange. And the reason why is that individual won't be eligible for a tax credit or subsidy through the exchange if the IRS determines that they had affordable employer coverage available. So it's something to keep in mind there. And just this next slide is going to show you not all employees are necessarily going to elect that coverage. So sort of an inverse triangle demonstrating how this will work. And we talked a little bit about the individual mandate and where individuals get coverage earlier, and this is sort of the reverse of that. So you start with, if you're a large employer, you start with your total number of full-time employees. That could be your maximum exposure under the law. Anybody working 130 hours a month. However, healthcare reform also requires group health plans to offer dependent coverage and to continue offering that coverage up to age 26. So if I'm a 25-year-old and my parents have healthcare coverage, even though I have a job and even though that job offers coverage, I might want my parents to pay for that coverage and I might stay on their health plan. Also, their plan might be better, so I might go to their plan. So just keep in mind that your young employees may go under their parents' plan. Also, as we discussed, a number of states are going to be expanding Medicaid, and it's likely that in those states, individuals who are eligible for Medicaid would go that route because that's, without a doubt, in most instances going to be cheaper than employer-provided coverage. You also might have other opt-outs for a variety of reasons. For instance, an individual might be covered under their spouse's plan. There are a number of other reasons why individuals might decline health care coverage. And that's where you end up with a much smaller portion of your employee population that would actually opt to elect health care coverage from you, and those would be the people you would have to pay for. Now, just keeping in mind here that there are models out there that exist now that you can run the numbers and see what the expected cost of paying the penalty versus the expected cost of offering health care coverage is. Now, I haven't worked through these models myself, but what I hear just secondhand is that in very few instances does it make more sense to drop coverage than to actually offer healthcare coverage to your employees. Now, I know that doesn't sound right, but you have to remember that there are going to be new products designed in 2014 that are specifically designed to offer the bare minimum while still satisfying the employer mandate. So those are going to look different. Theoretically, the cost of healthcare coverage will moderate somewhat. And we already saw it this year. It's been healthcare costs increased by the smallest amount in the last decade this year. So just something to keep in mind. And this is, again, just a high-level overview, but we do want to offer to take any questions to the extent anyone on the line has any.
Thanks, Ben, for covering that. That was really great. It looks like we're having some slight trouble with our question panel on the side of our webinar. So what I would ask is if anyone has any questions, they could email either of us. My email is JON at Employer Healthcare Congress, John at Employer Healthcare Congress, and Ben's is bconley at SEYFARTH.com. And then what we'll do is we will post on our website and our LinkedIn group any of the questions and the answers to it, and we can maybe continue that discussion on LinkedIn. So I want to thank everyone for joining us on the webinar. I know we have a couple hundred people on today, and look forward to future webinars. Thanks, Ben.
Thanks.